Assalamu alaikum. So I was asked to talk about approach to pancytopenia, thrombocytopenia, and anemia in 15 minutes. I'll do my best, but I cannot guarantee that. Okay, I'll start with pancytopenia. As the name suggests, pancytopenia is a reduction of all the three blood elements in the peripheral blood. It is a very common reason to refer to a hematologist. So out of 10 cases of pancytopenia, 9 of them are being referred to hematologists. And we have to realize that pancytopenia is not a disease by itself. It is a result of an underlying pathology, either in the bone marrow or the peripheral blood. And this concept applies for anemia as well. It is not a disease, it is a result of underlying pathology. However, thrombocytopenia does represent clinical and pathophysiological entities. So how do patients present? They either present acutely or chronically. And this will help us in the diagnosis. These patients may be actually discovered incidentally, though they are maybe asymptomatic. However, they can be very ill, critically ill in the ICU as well. And the main symptoms or clinical presentation of pancytopenia depends on the elements. So they will present with symptoms of anemia, recurrent of infections due to leukopenia, plus minus bleeding due to thrombocytopenia, which is not necessarily the case. Now, how do you investigate a patient with pancytopenia? There are some basic required investigations that should be done with each case of pancytopenia, and from there you go to your specific workup. So, of course, a full blood count, and then a peripheral blood smear, retic count, possibly LDH. These four are mandatory for any case of pancytopenia in order to know in which direction you are going to. And then, of course, you can include liver function tests, renal functions. These should be included initially because they are basic tests. Coagulation, PT, PTT, CRP, ferritin. And from that, you know in which direction you are regarding the etiology. So you can then order virology screen for the famous parvovirus, HIV, hepatitis C, hepatitis B, and of course our new guest, COVID. You can request, of course, according to the presentation and the result, labs for collagen vascular disease, flow cytometry for PNH if you suspect PNH, chronic infections like TB, leishmania, malaria, and if you are suspecting congenital aplasias, then you can order NGS. And of course, bone marrow aspiration and biopsy is one of the main corner tests that should be done for pancytopenia accordingly. And if patients have palpable lymph nodes, you have to take one lymph node for histology. Now, what are the main categories of etiology of pancytopenia? We can categorize them into impaired production, and these represent a central cause of pancytopenia, and peripheral destruction, where elements of the blood are being destructed peripherally or sequestrated in the spleen. However, keep in mind that pancytopenia does not necessarily fall in one of these categories. We can have multiple causes of each case of pancytopenia. Examples for impaired production, of course, central causes in the bone marrow, like aplastic anemia, whether congenital or acquired. We can have infiltration of the bone marrow, like any malignancy infiltrating the bone marrow, infections, or a primary bone marrow disorder like aplastic anemia, multiple myeloma, hairy cell leukemia, chronic leukemias. Myelofibrosis is a very famous cause of pancytopenia, granulomatous disorders, metabolic disorders, and we have nutritional deficiencies, vitamin B12, folic, and copper. And of course, we shouldn't forget MDS, myelodysplastic syndrome. Now, what are the peripheral causes of pancytopenia? We have mainly immune. So we can have immune, mainly immune dicytopenia or immune pancytopenia. So the elements will be destructed by an immune process peripherally, and we can have the elements of the blood sequestrated in the case of hypersplenism and splenic sequestration. Examples of a combination of causes or etiologies can include a famous example of PNH. So in PNH, you have bone marrow hypoplasia and a chronic Coombs negative intravascular hemolysis, and the other examples that are listed. So keep in mind that in each case, or in some of the cases of pancytopenia, you can have multiple causes for pancytopenia. Even in the general medical cause like chronic liver disease, you can have hypersplenism, sepsis, folate deficiency, and accordingly, probably alcoholic liver disease as a cause of chronicity of the liver disease. Now, I just choose copper deficiency. Why? Because it is slightly unthought about. We don't usually think about copper deficiency. It mainly causes neutropenia and thrombocytopenia. However, it can cause pancytopenia as well. And in the bone marrow, you will see vacuoles, as you can see here, both in the myeloid and in the erythroid lineage. These vacuoles are suggestive of copper deficiency as a cause of dicytopenia or pancytopenia. And this graph just tells you that the etiology is actually of pancytopenia is dependent on many other factors, and we will talk about this in the coming slides. So etiologies differs according to the geography, according to the socioeconomic status. So this retrospective study was conducted in Pakistan, and as you can see here, nutritional causes of pancytopenia ranked the first, while AML, aplasia, and erythroid hyperplasia came later. I'm sure that if there is a retrospective study in USA or Europe, probably the sequence of etiological causes will differ. Now, there are hints that you have to keep in mind when you approach a case of pancytopenia. We have epidemiological hints, we have probably clinical hints. So epidemiological hints, as I said, that pancytopenia, the causes of pancytopenia differs according to the socioeconomic status, according to geography. So in areas where you have limited resources, you should think about malabsorption, about infections. However, thanks to bariatric surgery, still you should think about nutritional deficiency because of that. HIV, alcohol as causes of pancytopenia are related to some social behavioral patterns, and age is a very important factor when you approach a case of pancytopenia. In children, you have to bear in mind congenital causes of bone marrow hypoplasia, while in adults you have to think about acquired causes. However, keep in mind that some causes of bone marrow aplasia appearing in adults or HLH can be due to genetic inborn errors which have low penetrance, and they only show later in adulthood, and they sometimes need a trigger factor, an external trigger factor. So those were the epidemiological hints. What about the clinical hints that might help us to approach cases of pancytopenia? If pancytopenia is acute, so we have to think about sepsis or idiosyncratic drug reactions. All the other causes are mainly or probably will lead to subacute or chronic pancytopenia. Now, the severity of pancytopenia. You rarely have severe pancytopenia in cases of megaloblastic anemia or in hypersplenism, especially due to liver cirrhosis. While with bone marrow aplasia, aplastic anemia, the pancytopenia is severe, with a retic count of less than 500, platelets of less than 20. Having said that, just remember that in megaloblastic anemia specifically, they may present with severe anemia, reaching even 2. We have seen cases of megaloblastic anemia patients attending the emergency with a hemoglobin of 2. How the platelets and the white blood cells are not usually so low. So the platelets will be in the area of 40 to 70. Now, macrocytosis with pancytopenia, you should think about aplastic anemia, MDS, megaloblastic anemia, probably multiple myeloma, some medications leading to pancytopenia like hydroxyurea, and possibly immune. Pancytopenia with the splenomegaly. This is a very common clinical and theoretical question exam. Exam question, I mean. So when you see a patient with pancytopenia having a palpable spleen, you should think about chronic liver disease with hypersplenism, infections, viral, malaria, leishmania, TB, hematological malignancy, hairy cell leukemia, lymphomas, and MPNs, myeloproliferative neoplasm, mainly myelofibrosis, extramedullary hematopoiesis, like in thalassemias, chronic inflammatory processes like collagen vascular disease, Felty syndrome, rheumatic and rheumatoid arthritis, storage diseases like Gaucher disease or hemophagocytic syndrome. Now, if the labs tell you that there's DIC with pancytopenia, keep in mind acute promyelocytic leukemia as a cause, but of course you have to consider sepsis. If you have hyperferritinemia with pancytopenia, of course you have to consider HLH. Now, this is a graph or an algorithm which is suggested by this group of investigators who published in blood reviews. And this is basically a summary of what we have just said. The aim of having this slide is to pass a message that sometimes at the end you may not reach a reason for pancytopenia. And this entity is labeled as idiopathic cytopenia of undetermined significance. So just like gammopathy of undetermined significance or other clinical entities of undetermined significance, we have idiopathic cytopenia of undetermined significance, which is thought mainly to be due to immune reasons. Now, this is just to show you how can peripheral pancytopenia be associated with a hypoplastic bone marrow, like in aplastic anemia or hypoplastic MDS, while you can have empty blood and full bone marrow. So empty blood, pancytopenia, and full bone marrow, like in megaloblastic anemia. So bone marrow is hypercellular, while the peripheral blood is pancytopenic. This is seen in megaloblastic anemia, in MDS, in hypersplenism, and in cases of infiltration of the bone marrow. Okay, now what about anemia? So this was about approach to pancytopenia. What about approach to anemia? Keep in mind that anemia can be relative or absolute. So relative anemia is due to an increase in the plasma volume rather than a reduction of the red cell mass. An increase in the plasma volume can happen with macroglobulinemia and with a pregnancy, sometimes with the astronauts, while reduction of the red cell mass represents a true anemia, absolute anemia, and it can be due to, again, central causes of erythroid production or peripheral causes of RBC destruction or blood loss. And there are many examples for each. What are the two pillars that you should depend on in order to approach a case of anemia? These are MCV and the retic count. MCV and the retic count. So when you start with MCV and you have a low MCV, you should do iron studies. And when you have low iron and high total iron binding capacity and low ferritin, then you are classically dealing with iron deficiency anemia. If you have low iron with normal or low total iron binding capacity, with normal or high ferritin, of course, you are dealing with anemia of chronic inflammation, anemia of a chronic disease. If you, on the other hand, have normal or high iron with a variable total iron binding capacity and normal or high ferritin, you can either have iron overload clinical cases like sideroblastic anemia, or you may have, if you have teardrops in the peripheral blood, target cells, splenomegaly, and in the history you have positive family history, then you may be dealing with hemoglobinopathies, beta thalassemia. Now, if you have normal MCV, you should do, of course, retics, because this will lead you whether you are dealing with cases with a normal MCV, which are hypoproliferative cases, and in that case, you should do bone marrow. You should directly go to the bone marrow and do biopsy, or you are dealing with normal MCV with hyperproliferative case, then you are dealing with peripheral pancytopenia. So if you have high MCV, then the high MCV, you are dealing mainly with megaloblastic anemia. But if you have in the peripheral blood dysplasias, then you are dealing with possibly myelodysplastic syndrome, and then you have to go to and do bone marrow biopsy. So this was approach to thrombocytopenia, and now approach to anemia and thrombocytopenia, and this is my last slide. So thrombocytopenia, again, you have to keep in mind that it might be pseudo-thrombocytopenia, and for that, you have always to do a manual count or a blood film in order to see platelet clumping. But if you have a true thrombocytopenia, then if the peripheral blood shows schistocytes, then you are dealing with thrombotic microangiopathy, TTP, hemolytic uremic syndrome, DIC, and other causes of thrombotic microangiopathy. If there are blasts or nucleated RBCs or dysplastic features in the peripheral blood, then you have to do bone marrow in order to look for central causes of thrombocytopenia, like acute leukemia or MDS. If you have anemia in addition to thrombocytopenia and evidence of hemolysis, then you are probably dealing with Evans syndrome, in which you have immune thrombocytopenia and immune anemia. If you have in the peripheral blood what suggests infection, like lymphocytosis or toxic granulation, then consider infection and do the septic workup and virology screen. And ultimately, or eventually, lastly, if you have isolated thrombocytopenia, then you are dealing with the famous ITP, and you have to look for whatever is associated with ITP, like hepatitis C, HIV, H. pylori, or other causes. And with this, I will close, and thank you for listening.